Good morning, everyone. Welcome to Chicago. Welcome to the 2014 Congress on Healthcare Leadership. I'm Deborah Bowen, President and CEO of ACHE. I hope you enjoyed the video. We were hoping that it would energize you about Congress and help you understand how we're serving you and how we're advancing the profession of healthcare management. You all are making a tremendous difference in the work you do to advance patient care. And we honor you and we celebrate you, and I'm so glad you're here with us today. Whether this is your first Congress or your 21st, know that you have gathered with some of the best and brightest in our field to exchange knowledge, spark ideas, and generate solutions, moving us on our pathway to greater value for patients and communities. As the map on the screen indicates, there are over 4,000 registrants here from 32 countries, and we welcome you no matter how far you've traveled, whether close or whether far. Welcome to this event. We are pleased you are here with us today, and this is an important part of your professional development. At yesterday's convocation ceremony, we honored ACHE's new fellows. And I'd like for you to join me in really honoring those who are in the room who attained the status of the FACHE. Will those of you who are new fellows please stand? I'd ask all the fellows to stand, but that would be a very large group, so I don't think I'm going to do that. It is now my honor to welcome and opening the session and obviously welcome you to the Parker B. Francis Distinguished Lecture. This lecture is really made possible by the support of Aramark, who is one of our ACHE premier corporate partners, so I hope you will join me in thanking Aramark. You're going to meet one of them in just a few moments. Thank you, Aramark. One of the wonderful honors we have this morning is to introduce the 2014 Gold Medal Award recipients. The Gold Medal is ACHE's highest honor. To determine the annual winners of our Gold Medal Award, we rely on the judgment of a special committee charged with that assignment. ACHE's Gold Medal for Excellence in Leadership in Healthcare Management recognizes exceptional achievement in the areas of leadership and executive performance, health service delivery, education, management, and organizational development, and health-related community affairs. Our 2014 Gold Medal Award winners have been exemplary leaders in their communities and nationally. Whether implementing new services or better meeting the healthcare needs to advance our profession, they are stellar examples of what it means to be a leader. To present the first award, I call on Di Smalley, our immediate past chairman. Di.
Whether working to make the lives of children in rural Pennsylvania better, leading a multi-hospital system, or developing health services in Africa and Latin America, our first 2014 Gold Medal winner has demonstrated unfailing compassion for his fellow man and exceptional leadership of the healthcare field. Charles Evans began his career in 1971, working as a counselor and social worker as part of a child guidance team serving public schools in rural Pennsylvania. He then worked for an area community mental health center in various leadership roles. In 1980, Charlie joined Community Hospitals in Indianapolis as Associate Director, Professional Services, and Administrator for Gallahue Mental Health Center. 6 years later, he was promoted to Executive Vice President and COO. In 1989, Charlie joined Memorial Medical Center in Jacksonville, Florida, as its president, and 6 years later, the organization merged with Columbia HCA. It was then that he was named president of HCA's First Coast Health Network before being promoted to president of HCA's Mid-America Division in Nashville, Tennessee. In 2001, Charlie was named president of HCA's Southeast Division in Alpharetta, Georgia. And in 2004, he was named president of its Eastern Group in Nashville. Charlie retired from HCA in 2007 and founded his own company, International Health Services Group. You can read about Charlie's many accomplishments in your program, but some of the highlights are as follows. During his time leading HCA's Eastern Group, Charlie was responsible for the operational success of 120 hospitals with revenues of $12 billion. In addition to the financial performance, he oversaw the group's disaster preparedness and diversity plans, as well as the ethics and compliance and clinical quality initiatives. And with his current organization, International Health Services Group, which supports health services development in underserved areas of the world, Charlie and his organization have provided their clinical skills around the world. He assisted a clinical services development in Kenya, conducted medical needs assessments, and provided ongoing support for a new maternity ward in Punta Gorda Hospital in Belize, and upgraded a medical and dental hospital in Nigeria. Charlie serves or has served on several corporate boards. He is a board member for Jackson Healthcare in Alpharetta, Georgia, MyMedics in Marietta, Georgia, and CareSpot Express in Brentwood, Tennessee. He is also a member of the Georgia Association of Healthcare Executives and served on the board of directors of the Georgia Hospital Association and on the board of directors of the Tennessee Hospital Association. And in 2012, he attained the Board Leadership Fellow credential of the National Association of Corporate Directors. Charlie earned an MBA from Indiana University School of Business and a master's degree from Indiana University of Pennsylvania and a bachelor's degree from West Virginia Wesleyan College. Board certified in healthcare management as an ACH Fellow since 1999, Charlie currently serves on the Counselors Committee. He has received an Exemplary Service Award, Distinguished Service Award, and Regents Award. From 2004 to 2007, he served as a governor, and from 2008 to 2011 as chairman-elect, chairman, and immediate past chairman. In his many years in ACHE leadership, Charlie has had a dramatic and lasting impact on the profession. For his leadership that has influenced not only the healthcare system locally, regionally, and nationally, but internationally as well, the Board of Governors of the American College of Healthcare Executives is pleased to bestow its 2014 Gold Medal Award on Charlie Evans. Charlie, would you come to the lectern, please?
Wow. It kind of sounds like I've had trouble keeping a job, doesn't it? Thank you, Di. And thanks to the ACHE board and to all of you for this recognition. The gold medal is made even sweeter for me because I'm sharing the recognition with my most deserving friends, Chris and Rosemary Van Gorder. Congratulations. As I've thought about what I might say this morning, I've struggled with all the things I'd like to tell you. I want you to know about my wife, Chris, who died nearly 4 years ago and who was at the center of my personal and professional life. I'd like to tell you about my experiences in Russia 25 years ago, where I had an opportunity to see firsthand the incredible difference that professional management makes in healthcare. And I'd like to tell you about the thousands of outstanding people that I've worked with over the years, and particularly those who took the time to support and mentor me along the way. Instead, let me simply encourage you to treasure every moment with your family and do your best to make sure they know how much you love and appreciate them. Stay tuned in to how blessed we are to be a part of this profession, and recommit yourself to lifelong learning and to advancing the profession in every way that you can. And take advantage of opportunities to coach and mentor those around you who are striving to be more effective leaders. There's nothing that we can do in our professional lives that will produce longer lasting positive ripples than playing a role in the development of leaders. Thank you very much.
Wow. To present the next 2014 Gold Medal Award, I call on Richard Cordova, who is ACHE's chairman-elect. Rich.
Good morning. Thank you, Deborah. Our second 2014 Gold Medal winner was a police officer early in his career, and the department's motto at that time was responsible to all, second to none, every time, which is also fitting description of the leadership exhibited by Christopher Van Gordon throughout his career. Chris began his career in 1973, working his way through college at a local hospital. He left the hospital business to become a police officer in the city of Monterey Park, California. After several years of service, he was severely injured in the line of duty and retired from the department. The hospital that he provided much of his care, Orthopedic Hospital in Los Angeles, hired Chris in 1980 as a department director in support services. It was during the next few years that he found his calling as a healthcare and hospital administrator. In 1986, he took the position of vice president at Anaheim Memorial Hospital, where he was promoted 5 years later to senior vice president. In 1993, he joined Little Company of Mary Health Services in Torrance, California, as executive vice president, serving there for 2 years before returning to the renamed Anaheim Memorial Medical Center as president and CEO. The organization became part of the memorial system, and when in 1997, Chris was named executive vice president and CEO of Long Beach Memorial Medical Center. He left there in 1999 to take a position as chief of healthcare operations and executive vice president for Scripps in San Diego. He was promoted the following year to his current position as president and CEO. You can read about Chris's many accomplishments in your program, but some of the highlights are as follows. When Chris was asked to lead Scripps Health, he took over an organization that was gridlocked with physician population publicly fighting the system's strategies, afflicted with employee morale that was at an all-time low, and faced with financial crisis. He responded with implementing a transparent co-management style, configured an award-winning executive team, streamlined business operations, and focused on patient care, physician relations, and workplace culture. A few years later, Chris and his team mobilized an army of resources to Houston to care for thousands of Hurricane Katrina evacuees. And in 2010, he led another team to Haiti to aid earthquake victims. In 2013, Chris received the Press-Ganey Innovation Award and was awarded the California Distinguished Service Medal from the California Emergency Medical Services Authority. And in 2009, he received the B'nai B'rith National Healthcare Award. Chris graduated from the University of Pennsylvania Wharton School of Healthcare System CEO program, earned his master's degree in healthcare administration from the University of Southern California, go Trojans, and his bachelor's degree in political science and public administration from Cal State University, Los Angeles. He is also a certified emergency medical technician, board certified in healthcare management as an HCS fellow since 2001. Chris currently serves on the Counselors Committee. He has received an Exemplary Service Award, Distinguished Service Award, and Regents Award. From 2006 to 2009, he served as governor, and from 2009 to 2012 as chairman-elect, chairman, and immediate past chairman. In his many years at HCHE leadership, Chris has made a dramatic and lasting impact on the profession. For his dedication to advancing healthcare excellence and commitment to service of his local community and of the nation and internationally, the Board of Governors, the American College of Healthcare Executive, is pleased to bestow the 2014 Gold Medal Award on Christopher Van Gordon. Please come up, Chris.
Well, good morning. Before I make any other comments, I too want to recognize Charlie Evans, one of the most honorable gentlemen I think I've ever known in my life, and I am truly honored to share this award with Charlie and Chris. God bless you for all of your service, Charlie. Well, I will tell you, standing up in front of you today is a long way from about 35 years ago when I was in a critical care bed after being hurt as a policeman. And at that point, I knew my career was over and had no idea where it would go. And as I've often said many times since, your worst day could absolutely be your best day. If it hadn't been for that injury, I never would have ended up in healthcare, never would have met my wife, who I met at Orthopedic Hospital. She was a department director in the child life program there. Wouldn't have the two boys that I have today. One's a high school teacher and the other now is working at Rady Children's Hospital as an administrator. And I wouldn't have the chance to stand in front of all of you and have had the blessing of being part of the ACHE for now more than 30 years. It is pretty amazing how, and I guess I've said for many times, that for whatever reason, I fell up instead of falling down when a lot of people can fall down. Who would have ever thought 30 years ago when I was looking for a job, and I remember going to Orthopedic Hospital, who was looking for a head of security. And I met with the chief operating officer, and he said, well, why should we hire you? And I said, I'm not so sure why you should hire me. But I said, tell you what, pay me minimum wage, give me a chance for 90 days, and if you don't like me after that, I'll just leave on my own. You won't have to do anything. And of course, at the end of 90 days, thank God he decided to keep me. And then I decided that I was going to be on a different path. And this was, instead of a path in law enforcement, it was going to be a path in healthcare. Shortly thereafter, I had the blessing of a new boss, a new CEO, who ended up becoming a lifelong mentor, as many people do. And he was a regent with the college, and he absolutely insisted that all of his senior people and department heads joined the college, and I certainly joined when I was at the University of Southern California, and today represented by Dean Jack Knott, who's the dean of the program. And God knows they didn't think I'd ever be standing in front of you today. But I ended up working full-time and going to school full-time and had a chance then to get into administration. Bounced around, I guess Charlie and I are the same way. You wonder if you can keep a job, but I think that's the way it is a little bit in healthcare. As the career moved forward, I found myself in the end at Scripps Health, and a number of the executives are here today and represented by board chair Maureen Stapleton, and my senior leaders, and a number of my chief executives and senior leaders all sitting here today. 7 of them got their fellowship yesterday. I'm so proud of them and everybody else that got their fellowship. And as they were crossing the stage yesterday, I just kind of thought back of what a fabulous and lucky person I've been falling up. I had a chance after Hurricane Katrina. We had built a medical response team. The intent was to support our own community, and received a call from then Surgeon General Richard Carmona asking us if we would deploy our team to Katrina. We ended up in Houston and having a chance to work for Captain Gene Migliaccio, who's here today, who was our commander. He helped swear us in and pointed out that we were unpaid volunteers working for the government. But it was a blessing. Gene and I got a chance to work together and decide what we needed to do with our resources to help those people, those survivors, as they wanted to be called, from Katrina. And just a few years later, had a chance to take in, with the support of Med Assets and John Bardis, and Rand Ballard's here today, who flew us into Haiti at 2 o'clock in the morning. And for the next 3 weeks, we took care of survivors from the massive earthquake. And working with my chief medical officer, then chief medical officer, Dr. Brent Eastman, who has just retired as the president of the American College of Surgeons. And I'll never forget walking, as we did tours of the hospital, St. Francois de Sales, which was completely destroyed, over 250 dead bodies in the building. They didn't get them out for 9 months. So you can imagine what the smell was like there. Walked around with a group of Belgian surgeons. We saw one patient, a gentleman by the name of Jean Candio, somebody I will never forget, who had bad compartment syndrome to his arm and his leg, about ready to lose his limbs with ripsaw, which is what they were using before we got there, with anesthesia with ketamine. That was all they had. And so the Belgian surgeon asked Dr. Eastman, he said, do you know what the problem here is? He says, yeah, compartment syndrome. He says, do you know how to do the surgery? Well, he's an expert trauma surgeon. He said, yes. And they took out a little red ribbon, tied it to the end of the bed. And Brent said, what's that? He says, that's the pre-op order. He's now your patient. And so Brent said, well, where's my surgical team? And they pointed to me, said him. And so Brent said, are you up for it? And I said, just don't let me kill anybody. And we operated for the next week together. You don't see too many chief executives that are not physicians having a chance to operate with their chief medical officer. And again, the only reason that could happen is there are no lawyers in Haiti. But that's something I will never have a chance to do again. And it was fabulous to work side by side with him and all the rest of the team that ended up coming, and we saved a lot of lives. We didn't worry about billing. We obviously didn't worry about regulations. And we took care of a lot of good people and worked with the 82nd Airborne and all the other volunteers, work that Charlie continues to do today in Haiti and around the world. And I will tell you, laying on that bed 35 years ago, I never would have believed I could do any of these things. So for all of you young folks in the room that aspire to be in healthcare administration and to ultimately run your own organization, you can fall up as well. Just stay with the college, listen to your mentors that are throughout this room, take advantage of what this organization can give to you, and there will be greatness that follows. God bless you all. Thank you.
Well, it's obvious why Chris and Charlie are our 2014 Gold Medal Award winners. Let's give them another round of applause. It is now my pleasure to introduce Christine Candio, your new chairman. Chris is CEO of Inova Alexandria Hospital in Alexandria, Virginia, and senior vice president of Inova Health System in Falls Church, Virginia. Chris has served in her current position since 2008. From 2003 to 2008, she was executive vice president of Hallmark's Health System, Lawrence Memorial Hospital in Melrose, Massachusetts. She also served as the organization's vice president of patient services and women and children's services from 2002 to 2003, as assistant director of women and children's services from 1999 to 2002. My favorite part, board certified in healthcare management as an ACHE fellow. Chris served as an ACHE governor from 2010 to 2013 and as president of ACHE of Massachusetts, an ACHE chapter, from 2004 to 2007. Chris received her master's degree in public administration with focus on healthcare management from Farley Dickinson University and her bachelor's degree in nursing from William Patterson College of New Jersey. It is my very great honor and pleasure to welcome your 2014-2015 Chairman, Chris Candio.
Good morning. Chris and Charlie, congratulations again on an incredibly well-deserved honor. I'm going to try again. Good morning. Good morning. All right. It is such an honor to be here today. The opportunity to be your chairman is a highlight of my career and a major milestone in my life. Now, as I start, I'd like to acknowledge some very special people. So I'm going to ask you all to bear with me because we're going to sound a little bit like we're at the Academy Awards. Okay? Here goes. Many of my team members and people that are very important to me are here with us today. First, my boss, Mark Stoddard. Mark is the president and COO of Inova Health System. And a number of executive team members are all here to support me, and I want to thank you all for your guidance, your support, and I appreciate it. My past boss and mentor, Michael Sack. Mike is the president and CEO of Hallmark Health in Melrose, Massachusetts. Mike supported me in my development as a leader and was my safety net as he allowed me to be a risk taker and grow professionally. Dr. Robert Wicks and Michelle Wicks, not only my aunt and uncle, but my friends. These are two people that have always been there to support me and guide me. My parents, now both deceased, they were my cheerleaders from the day I was born to the day they drew their last breath. They taught me there was nothing I couldn't do in my life. To be strong and fearless, but always with love, compassion, and to celebrate each day as a gift. Next, my son, Jason. At 29, I know I still embarrass him because I call him my baby. But it is what it is. When I started grad school many years ago, he believed in me, cheered me on when I most needed it, working full-time and raising a family. He always provided encouragement, and that has not changed present day. Last, and definitely not least, my husband, Vincent. He is my ultimate cheerleader. From the time we met, believe it or not, way back when in high school, yes, my high school sweetheart, which includes almost 31 years of marriage. He's taught me not to take myself too seriously and learn to laugh at myself. And at times that was a really hard lesson. He was very persistent, but I think I got it. He provides me counsel in all facets of my life and career. Vinny is a kind soul, a good person, and I am very blessed to have him in my life. So thank you all for being here. "30 years ago, I started my career in healthcare as a bedside registered nurse. My goal was to comfort and care for patients during their most challenging and vulnerable times in their lives. At the beginning of my career, I quickly realized that working in healthcare was so much more than a job, regardless of the position, in healthcare. It's more than a job and something that you just leave behind when you walk out the door. As a nurse, you're continuously assessing and coordinating medications and treatment plans for your patients. As a leader, reflecting on employee, patient, and community engagement. Financial, and of course, strategic initiatives, and patient safety. This all includes our journey to most effectively redesign the delivery of healthcare. And these are just to name a few things. I look upon our profession as a vocation. It's something I live and love to do. Always on a continuous path of learning, which is why I decided to join ACHE many years ago as a student associate. So I stand before you today as someone with strong commitment, respect, and passion for our profession. As leaders of our industry, we face enormous challenges and great opportunities. No question, we are in a sea of change. We manage with greater transparency to outcomes, with an increased focus on preventive measures and wellness programs. We partner with a more educated, sophisticated, and diverse consumer. We have advanced research, improved technology and practices, and at the same time, we manage our costs while balancing that with reduced reimbursements. Again, these are just to name a few. Most importantly, through it all, we manage and lead with integrity. Integrity to be true to our industry's mission, our organization's mission, and ourselves. So thinking in terms of a sea of change, it reminds me of trips to the beach. Now stay with me on this. It's so exciting to see those waves, isn't it? And to take those first steps cautiously into the water, initially up to your ankles, and then soon up to your knees. Before you know it, you're swimming, floating, riding the waves. But regardless of the activity, stepping in brings a certain uncertainty and inherent risks, be it the tides, currents, unpredictable waves. So what does the smart water enthusiast do? They assess the dangers and strategically navigate a course that will minimize risks and maximize opportunities. They achieve this by identifying and managing their strengths and weaknesses, and always with a vision and focus leading them. Without, the individual finds themselves pushed and sometimes controlled by the tides and the currents that has moved them further from their base on the beach, and at times fighting and struggling against the water's power. Similarly in healthcare, change is important. It needs to mean progress. We need to step into that water, especially with all the forces driving the marketplace. But like the smart water enthusiasts, we must strategically navigate our path through the currents and tides, using our strengths, knowing our weaknesses, and never forgetting our vision of who we are and where we need to be. In essence, it's keeping an ear to the ground, an eye to the future, and anchoring your gaze on your true north. It is so exciting as we are gathered, surrounded by our peers, leaders from throughout the country and internationally, and the leaders of our professional organization, ACHE, to share knowledge, ideas, and learn. The essence of bringing it all together to continue to improve our healthcare industry. With these changes upon us, it is imperative that collectively we continually work on improving the value proposition to our patients and communities we serve, focusing on quality and safety, the patient experience, and affordability. I believe one important way to embrace and actualize this value equation is through our ACHE values. Lifelong learning, whereby continuous learning is essential to our ability to innovate, improve ourselves, our organizations, and our profession. Leadership, leading through example, through mentoring, and by advancing and promoting our mission. Integrity, advocating and emulating high ethical conduct. And diversity, advocating the inclusion and embracing and celebrating the wonderful differences among us. Knowledge, providing our members, all of you, with the timely tools and information we all need to excel in our profession. Career advancement, delivering programs, products, services that advance professional excellence. So it's very easy for us to get mired down with the multitude of demands that are upon us in an ever-changing environment. Yes, this is a business, but it's so important to always remember that we're here to serve. Serve our patients, serve our community, and serve one another, our colleagues, and our team members. And it is upon us to ensure the delivery of our message is heard through our leadership in our actions and communications. Many years ago, my dad was the director of mission effectiveness in a healthcare system. In his words, the idea behind mission effectiveness is supporting each other and working together toward a common goal. I often think of these words throughout my journey of strengthening our team engagement and being a servant leader, effectively partnering with team members as we all work toward a common goal of serving and achieving that value proposition for our patients and community is an important key to our success. So let's continue our talk about the core of why we do what we do, and hopefully what brought all of us into healthcare, regardless of which segment of the industry, and that is about the patient. Our patients come to us from all walks of life and in various settings: outpatients, inpatients, emergency patients in the field and in the hospital, beneficiaries of third-party payers. Again, these are just to name a few. They are often anxious, frightened, filled with questions, and in need of guidance and navigation. As leaders, we work so hard at trying to connect all those dots, ensuring seamless care across the continuum. Focusing on the patient and community we serve always helps ground me. It's so much more than addressing the physical needs and ailments of the individual. We need to look at those in need from a holistic perspective. We need to embrace and take into account the cultural diversity and individual needs of those we serve. So I'd like to share 3 very short vignettes with you. First, the 90-year-old woman who lives alone and would frequently call 911. Not because she had a medical emergency, because she couldn't lift the bag of food to feed her pet. EMS connected her to community services, not only to provide assistance in the home, but to provide companionship. The next example. A newborn baby girl was admitted to our neonatal intensive care unit. She was there for over 4 months. During that period, our respiratory therapist provided care to her and developed a wonderful relationship with her parents. There were a few times when the care team thought that the baby wouldn't survive due to her prematurity and critical condition. According to Tim, our respiratory therapist, this little baby was one of the sickest patients he had ever cared for in his 23 years as a therapist. Tim's bond with the parents and the baby's older sisters continued to grow. The little girl was quite a fighter, and against all odds, kept improving until she graduated from the NICU. Now, fast forward 3 years to present day. This beautiful baby, now 3 years old, was Tim's flower girl in his wedding just a few short months ago. Last example. Very recently, a lovely woman came into my office. She wanted to speak with me. She's also one of our auxiliary members. But she wanted to speak with me as a mom who lost her son 26 years ago. She lost her son from a fatal gunshot wound, and his name was Jamie. Jamie was 23 years old, an avid hockey player. He was involved in his community church, and as his mom shared, he was a kind and giving individual. Jamie's mom was giving donations in her son's memory, and again wanted to thank the ICU staff for the incredible care, understanding, and compassion they showed Jamie and his family during the most intense, painful period in their lives. In the family's words, our healing actually began with our ICU experience. These are examples of how powerful of an impact we all can have every day, even 26 years later. So what fuels us are the relationships we develop. It's so important as human beings. We thrive on relationships we have with one another. We draw from each other's strengths and help each other when there is a weakness. So let's face it, life is fundamentally about the journey. It's about life's experiences. I feel we need to role model that and remind ourselves of that every single day. As leaders in one of the country's leading industries, we've done many more things right than wrong. However, our willingness to adapt to change, acknowledge our imperfections, and to innovate will determine our success going forward. And that begins with ourselves and our willingness to step back, stay focused on the big picture, and open our minds of new ways of doing things. So while we may be in the midst of transition, some of which we question, even shake our heads at, we must not lose sight of the enormous positive opportunities being created for us to capture and develop. It falls upon us as healthcare leaders to harness that and begin shaping the healthcare industry of tomorrow. During my tenure as your chairman, I am committed to serving our members, to continue to support and strengthen our strategic plan. Our industry faces challenges. So does ACHE. As you all know, ACHE was founded in 1933. We have a strong, rich foundation with numerous core strengths and successes. We need to continue to build upon these. As we do, we ask ourselves, how does ACHE need to evolve to ensure relevancy for healthcare leaders? Some of the challenges we face include the pace of change altering the structure of the industry. It requires new and much more integrated models of care. We see healthcare executives entering the field from non-traditional backgrounds. And we are all facing limited financial resources, especially for professional development. Yet we know there has never been a more important and exciting time to be a healthcare leader for our patients, for our organizations, and for our communities. That is why we need to ensure that ACHE continues to be a value add to members. As a board, we have a number of strategic opportunities which we'll be exploring. Some of them include exploring new methods to deliver value to the profession and our members, adopting a stronger collaborative approach to expand our reach and impact across traditional boundaries. Our American College of Healthcare Executives must continue to be at the ready to respond and support our healthcare leaders, both present and future. On behalf of the Board of Governors, we take that on with great energy and enthusiasm. According to Wikipedia, a servant leader is defined as one who shares power, puts the needs of others first, and helps people develop and perform as highly as possible. It is in servant leadership to you, our members, that I lead ACHE as your 2014-2015 chairman. I would like to close with a quote from William Arthur Ward. "The adventure of life is to learn. The purpose of life is to grow. The nature of life is to change. The challenge of life is to overcome. The essence of life is to care. The opportunity of life is to serve. The secret of life is to dare. The spice of life is to befriend. And the beauty of life is to give." Thank you all very, very much.
Thank you, Chris, and congratulations again. We look forward to your leadership in the coming year. Now it's time for the Parker B. Francis Distinguished Lecture. And to introduce our speaker today, I call on Ken Sandifer, President of Aramark Healthcare Technologies. Ken.
Thank you, Deborah, and good morning, everyone. Susan Dentzer is Senior Policy Advisor at the Robert Wood Johnson Foundation. In this role, she works closely with foundation leaders to carry out the organizational mission of improving the health and healthcare of all Americans. One of the nation's most respected health and health policy thought leaders and journalists, Susan is also an honor analyst for PBS NewsHour discussing health issues. From 2008 to April of 2013, she was the editor-in-chief of Health Affairs, and from 1998 to 2008, she led the PBS NewsHour's health unit as on-air health correspondent and was a recipient of numerous honors and awards. Susan is also an elected member of the Institute of Medicine and the Council on Foreign Relations. We are honored to have her here today to deliver the 2014 Parker B. Francis Distinguished Lecture, Achieving the Potential of Health System Transformation. Ladies and gentlemen, it is my pleasure to present Susan Dentzer.
Thank you so much, Ken, and good morning to all of you. It's really a pleasure to be with you here in balmy Chicago. I say balmy because it appears to be about 10 degrees warmer than it's been most of the rest of the season. But of course, what's outside doesn't matter. What matters is what's in this room. And having just heard the accounts of the amazing Golden Award winners, I know that you are the industry ready to achieve the glories of health system transformation. I think it was Lee Iacocca who said that life affords us amazing opportunities disguised as insurmountable problems. And I cannot think of a better group of people to rise to those challenges, to those problems, and turn them into phenomenal opportunities for our nation's healthcare system than those of you who are members of this college. So thank you for the honor, the humbling honor of being with you this morning. So as you heard, my topic is achieving the potential of health system transformation. I'm going to say a few words about the background environment, not too many because you all know what the background environment is. Underscoring the need for innovation now, I'm going to offer a brief innovation framework culled from one of the most ingenious persons who ever thought about the topic of innovation. I'm going to offer some case examples and some comments about where we go from here. First, though, I'm going to start with a story. I loved hearing the stories this morning about the Golden Award winners. As a longtime journalist, I just love telling stories. So let me tell you one for a moment. Let me ask you to imagine that once upon a time there was a country out there somewhere with a pretty substantial economy, about the size of the economy of France, about $2.8 trillion in gross product. It had tens of millions of unhealthy people in it, though, really sadly, and life expectancy below 28, I should say, of the world's richest countries. Every day in that strange country, a group of the natives experimented on each other by giving them something that they called medical care, about half of which really had no evidence whatsoever that it actually worked or produced benefit. Strangely, in the process of providing all of this care, there were bad things that happened. They called them adverse events, and they were among the top 10 causes of death in that country every year, and in some years as high as number 3, the number 3 cause of death. On top of that, in this very strange land, while all of this activity was going on, there was also a large group of people, tens of millions of them, who were basically shut out of all of this, who didn't get any of this care, even the ineffective kind. They also particularly did not get the effective kind, and tens of thousands of them died every year as a result as well. And then just shockingly, partly because of the cost of all of this, especially that flawed care, this country was possibly going broke. So I would ask you, what would you have done with this country? Would you have sent in the Marines to rescue people from all of this flawed care or these injustices that some of them were receiving at the hands of others? Would you have sent in the International Monetary Fund, which of course goes to help countries that are getting into terrible financial difficulty and tries to set them on a right and sounder path? Would you have sent in Amnesty International to rescue these people from what were arguably human rights violations, getting this care that actually in some instances killed them, or getting care that had no evidence behind it? Or would you have done something else? Well, of course, we know this country's identity, don't we? This is the United States of healthcare. It is a system ripe for transformation. $2.8 trillion in gross product this year. Adverse events, the top 3 cause of death in the country last year. Tens of millions of uninsured still left. And of course, as the Institute of Medicine has calculated, large amounts of the care we provide with absolutely no direct evidence that it actually works. So this is us. And we know what this country did in 2010. We did not call in the Marines on ourselves. We did not call Amnesty International or the International Monetary Fund. What we did was enact the Affordable Care Act. Now, no law, even an ambitious one like this, is the equal of all of the problems that I've just described. And it's going to be tough. I spoke recently at the National Defense University, and they were sharing with me this very detailed list of the stages of a military campaign. I won't spend time on it. You do have my slides with you. But it basically talks about how some of the most important phases are not the invasion part, which is basically what they call phase 2. It's really stabilizing the environment, phase 4, and enabling a new system to thrive, phase 5. That's where the real effort goes. And you can see briefly on this chart the same point, that it's basically now, to draw an analogy to the Affordable Care Act, now that the reforms are in place, and the system transformation really has to take place, now is the hard part. Now is when the real difficulty arises. It's like a military campaign, and for the Affordable Care Act, we're arguably right there. What do we have to do in this campaign? Obviously, we know our marching orders from Don Berwick. They are the triple aim. What the country needs is better health care, and of course, we need it all to cost less. And when Don went to the Centers for Medicare Medicaid Services, he took this 3 triple-pronged aim with him and hung it over many of the provisions of the law in order to focus all of us on what actually had to be accomplished. So let's talk about those aspects of the triple aim for a moment. Let's talk about better health. This is an actual photo of the people lined up to get into Paula Deen's Lady and Sons restaurant in Savannah, Georgia last June. And you can see the profile, you'll excuse the phrase, of the people lining up to get into it. This is us. This is a picture of us as Americans, with 2/3 of U.S. adults overweight or obese. We're on our way to 80% of U.S. adults being overweight or obese by the year 2030, or as the comedian Stephen Colbert says, at that point, 80% of U.S. adults will be 160% of U.S. adults in terms of total weight. But this is us. The Institute of Medicine took a look at this a year ago and put out a very important report, U.S. Health and International Perspective, and said when we compare ourselves to all the other rich countries, we come up very, very far short. For many years, we as Americans have been dying at younger ages than people in almost all other high-income countries. Our lives are shorter, and we have a long-standing pattern of worse health across every stage of the lifespan, at birth, during childhood and adolescence, right up through middle age. This is just a quick chart that shows the months of life lost before age 50 for U.S. men compared to the average of all of the other rich countries. We are the red bars, the average of all the other countries are the gray bars, and you can see for almost any condition before age 50, we lose twice as much life as the average of all the other countries. All-cause mortality there at the bottom. Similarly for women, same story, slightly different conditions, obviously maternal conditions. Note that the red bar shows up on maternal conditions, no bar evident for the other countries. Once again, we lose twice as much life before age 50 for U.S. women. If we look at the issue of life expectancy across the country, an article that I worked on when I was at Health Affairs last year demonstrates this. Basically, if we look across U.S. counties, we see that female mortality is rising in 43% of U.S. counties, while male mortality rates increased in only about 3%. Here's what the map looks like. You can see the red areas are the areas for men on this map where mortality is rising. The blue areas are where things are getting better, and the green areas are where things are staying about the same. And you can see pockets around the country where male mortality is on the rise. Life expectancy for men is falling. That's the map for men. Now look at the map for women. This is what's happening to female mortality around the country. And you can see, particularly through what we caustically refer to as the stroke belt in the south and southeast, it is the case, but also very strikingly across the upper Midwest and into the upper Northwest. Rising mortality among women in almost half of the counties in the country. We know more and more about why this is, and particularly why our experience is so much worse than other countries. And Elizabeth Bradley and a colleague came out with a very important book last year looking at the imbalance between what we spend on healthcare in this country versus social services and social supports versus other countries. And you can see we are the country that is the outlier among all other countries. Other countries have a much higher ratio of social spending to healthcare spending. We're the opposite. We spend most of our money on healthcare and very little on social services supports. Maybe this is what comes of doing that. What are we doing about these challenges? Well, we know there is some good news. We know that some of our efforts, for example, to tackle child obesity seem to be working. The CDC recently reported a 43% decline in obesity among children ages 2 to 5. What got less attention when that report came out, though, is that everything else is about the same or getting worse. That's why we need better health. Why do we need better health care? Well, the Institute of Medicine told us in 2001 that if you're a well-insured American with access to the best systems in the country, many of whom are represented in this room today, you have the best health care that you can access any place around the world. However, we have some issues in our system. It's not as safe as it could be. It's not as effective, not as patient-centered. Care is not delivered in as timely a way as it should be. It's not as efficient as it could be, and it's not as equitable as it could be. We still have large racial and ethnic disparities. Other than that, it is a great system, but we do have these issues, the IOM said, that we need to attack. How are we doing all these years later, 13 years later? Well, we still think 1 in 3 hospital admissions is associated with an adverse event, and we learned just recently that 1 in 5 Medicare beneficiaries who stay in skilled nursing facilities experience an adverse event. The IOM says about effectiveness of care that some of the studies suggest that only 10 to 20% of clinical decisions made are based on evidence. 10 to 20%. Patient-centered, ask somebody who's had a major illness recently, like advanced cancer. Timely, diagnostic errors, we know, are the largest single cause of malpractice claims and cause an estimated 160,000 deaths per year in the U.S. Diagnostic errors. Efficient, well, we know we have a lot of issues still with care transitions estimated to account for a much wasteful spending, perhaps on the order of $45 billion a year. And of course, the disparities that I mentioned. And the biggest one of all, still, it looks like about 40 million in this country uninsured. If you look at the Joint Commission's most challenging requirements and how well the system does, the Joint Commission says 53% of hospitals aren't compliant with requirements to maintain complete and accurate medical records for each patient. 47% of hospitals did not reduce the risk of infections associated with medical equipment, et cetera, et cetera. 53% of critical access hospitals did not maintain fire safety equipment. We know we have the evidence that we are falling short of our own expectations. We know we need more high reliability in health care. And of course, Mark Chasson and others have been making a big point of this the last several years. If we were to achieve the Six Sigma status in healthcare, we'd have no more than 3.4 errors in every 1 million events. We are far, far from that goal. That's why we need better health care. What about lower cost? It's almost not even necessary to talk about this, but let's talk about it for a moment. The CMS actuaries are projecting now what is going to happen with respect to national health expenditures in the wake of passage of the Affordable Care Act. And we know that there has been some good news of late. Healthcare spending is growing at its slowest rate in more than 52 years. And in fact, in 2012, the share of GDP devoted to healthcare actually fell from 17.3 to 17.2%. Not enough to have a big national party, obviously, but a different phenomenon than we've seen in most recent years. However, those same actuaries don't think that this is going to last. They still project that at the end of the phase-in of the Affordable Care Act, looking well out beyond 2020, we will still see national health expenditures growing about 2 percentage points a year faster than the rate of growth of the gross domestic product on a per capita basis, so that the cost curve, so-called, will not have been bent or will not have been bent enough. Now, these actuaries are only human beings. They could be wrong about this, but they don't think so because of the fundamental forces that we think will continue to drive the rate of growth of health spending. We also know more and more about prices and the role of prices in our higher health spending. And this very interesting article in JAMA not long ago isolated the fact that since 2000, it's been the rising prices of hospital charges, professional services, drugs, devices, and administrative costs that have accounted for 91% of the increase in health spending. So it's not even what we often tell ourselves that it's rising volume. It's really that we're charging ourselves much more for it, rising prices. And we know that our prices are higher by substantial margins than prices charged anywhere else in the world for healthcare. Here's just one of many examples I could show you, which is the cost of an appendectomy in the United States versus, say, Spain. $2,600 in Spain, lowest price in the U.S., about $7,000. And of course, we know you can find a place that will give you the $28,000 appendectomy. More than 12 or 13 times what it would have cost you to get this similar surgery in Spain. We know that our system is riddled with variations. The Affordable Care Act ordered up the mother of all variation studies, which the Institute of Medicine produced last summer. We know that we've had longstanding variations that we have identified in the Medicare program. This shows the dark areas are the areas that have several times the rate of per capita Medicare spending relative to the lighter areas in this country. We know from the IOM study that about 3/4 of the cause of those variations in Medicare are differences in post-acute spending around the country, particularly home health care and skilled nursing care. But in private insurance, we see a completely different pattern. There, the variations are driven by differences in prices and the different prices that are paid around the country by insurers and other payers for health care. We also know that variations within the same physician practice can be as wide as they are nationally. The Institute of Medicine study said that about Massachusetts, looking at 2 particular procedures and seeing the variation nationwide, or the same variation within the practice that you see statewide or nationwide. So we know we have a lot to do to get more evidence brought to bear. But the cost of all of this is what I'm driving at here. With many of the new plans available in the health insurance exchanges, the deductibles for people are very high. You can see from this chart the average deductible for the so-called silver plans, more than $2,000 a year. This is money now that's coming out of people's pockets in a way that has not been the case traditionally for many who've had much more generous health insurance. It is incumbent on all of us now to ask, what are we charging for health care and why, and how can we justify these prices to ourselves? As we look at all of this, the need for better care, for better health, and for it all to cost less, we know we have to innovate and continue on a path to health system transformation. I'm going to turn to the thoughts of the master on this topic, Peter Drucker, who wrote this wonderful book almost 20 years ago. Peter identified some of the sources of innovation. He said, first of all, change always provides the opportunity for the new and different. So we have change now. It's the opportunity. The overwhelming majority, he said, of successful innovations actually exploit change. They don't cause the change. They actually pick up on the change and take advantage of it. And he talked about systematic innovation as being the purposeful and organized search for changes that can be exploited, one after another after another. He identified 7 sources for innovation: unexpected events, incongruity, the difference between reality as it is and how we imagine it ought to be, process needs, changes in industry or market structure, demographics, changes in perception, mood, or meaning. What is the drive for transparency except a change in our perception about what should happen with prices in healthcare? And then, of course, new knowledge, the scientific knowledge that comes about via, for example, genomics, and non-scientific knowledge, changes in understanding of how we can better manage through, for example, processes like lean. All of these are sources of innovation that the healthcare system now has naturally, right? All of these we instantly recognize are applicable to today's healthcare. So let's look at some quick case examples of organizations that are doing just this. And frankly, there are many of them, and many of you are sitting right here in this room, so forgive me if I isolate just a few. We know that the Affordable Care Act has new requirements on hospitals as a condition of retaining their nonprofit status to undertake community health needs assessments and then adopt an implementation strategy to meet them. Otherwise, you will all get a slap on the wrist of a mere $50,000 for not doing this. That is causing systems across the country to look at how they can best have an impact on population health. And they look at this health impact pyramid and see how you can have the most impact on health. And we see that it's not necessarily counseling and educating particular patients, as important as that is, or perfecting your clinical innovations. It's really getting down at these long-lasting preventive interventions, changing the context to make individuals, enable them to make better decisions about their care, and attacking the underlying socioeconomic factors: poverty, education levels, income, not traditionally in the wheelhouse of healthcare organizations. But if we are going to have an impact on population health, this is what we have to do. What are communities doing about this? You look out in Seattle and King County, where they've done a very detailed examination. This is a chart that shows in that area of Washington State how many years it would take for them to catch up with the life expectancy of that is the average of all the high-income nations that I showed earlier. And you can see they can target areas where it will take 42 or more years to catch up with the life expectancy in, say, Scandinavia. But by hot-spotting these communities, they've been able to go in and take advantage of, for example, this CDC-funded Communities Putting Prevention to Work obesity prevention grants. Caused, for example, Seattle Children's Hospital to get together and partner with the King County Public Health Department and start, first of all, do a meaningful assessment, looking around. What have we got here? What are our health assets in the community? What are our challenges? Well, we're surrounded by water, they said. The ability to swim correlates with household income. Safe water activities provide opportunities for important leisure time activity, but also for health. And also minority populations drown at far higher rates. So let's talk about a proposed solution. Everyone swims. And so there is a systematic effort now to increase access to local pools, water recreation, partner with nonprofits, community clinics, offer scholarships for low-income families for kids to take swimming lessons, etc. and using the captive waiting room audience in clinics to educate people about all of this. Everyone swims. Check it out on the Seattle Children's Hospital website. An innovation in population health. Result in 2012, King County youth obesity prevalence showed a statistically significant decrease due to this and other interventions. Innovating around quality, another important objective. And of course, due to the Affordable Care Act, we got the first ever national quality strategy with these 6 goals, as you see here. One of them, of course, improving the safety of care. We look around again and see examples of innovation here. One of them, of course, being Ascension Health. Here's a case study that the Joint Commission published a year or so ago. St. Vincent's Medical Center and Ascension Hospital in Bridgeport, Connecticut, essentially undertaking a whole series of interventions to get to the point where in 2010, pressure ulcers system-wide were 94% below the national average. How did they get there? Highly visible CEO and staff living safety as a core value, a lifetime learning mindset, storytelling and transparency about the stories of the patients within the system, and daily huddles, a sense of mindfulness, reminding ourselves every day that this is the objective, to care safely for patients. Other innovations are available on the Agency for Healthcare Research and Quality Innovations Exchange website. Here's another one around safety in Billings, Montana, the Billings Clinic, where a different approach was proposed, actually looking at instances of positive deviance. Essentially, let's find the instances where things are unexpectedly going right and then replicate those throughout the system. Partnership for Patients, as we know, unveiled under the Affordable Care Act, is now starting to see some real results. The national bloodstream infection rate, you can see there, dropping rather remarkably in the last several years as a consequence of it. So we have proof positive, we have proof of concept that these changes and innovation works. Another example, the hot spotting that has gone on in Camden due to the work of Jeffrey Brenner, where Jeffrey railed against the hospitals in the area for years until he finally got all the data about who was using healthcare in the city of Camden, one of the poorest cities in the country, and traced much of it back to the patients in one building, a building that happens to house a public housing structure that happens to house a lot of the area's dual eligibles. And just by virtue of identifying the care needs in that building and putting in place a team consisting in part of volunteer VISTA workers who would go and meet with these patients every day and undertake assessments, find out what their needs were, just with that approach managing to revolutionize the care that was delivered to those individuals and cut their superutilization rates dramatically. We know that we can apply these tools throughout the U.S. healthcare system. This is from a report by the Government Accountability Office that showed that 33% of Medicaid dollars throughout the U.S. in 2009 were spent on 4% of the patients. 4%. For the top 1%, as you see there, the average expenditures were almost $95,000. And for one individual in 2009, the expenditures were $44 million. $44 million. Now that's a super utilizer. And that's not positive deviance either. What we can learn now by isolating these instances of superutilization and tackling them, and the amount of money that we can save, not to mention the amount of care that we can improve, is staggering. Let me mention innovation and price transparency. Again, I could mention many examples. I'll just refer you to the work of the New Hampshire Hospital Association, which has argued now for hospitals in the state of New Hampshire to be as transparent as possible about the care that they provide. One example, a system I'm familiar with, Dartmouth-Hitchcock, posting now on its website what your costs are likely to be for various surgeries and procedures, depending on your level of insurance, and referring you to more sources of information. Why not be transparent about this? Why not surface what these costs are going to be, especially for patients in high deductible health plans? Really, there's no excuse for us not to be doing more and more of this and providing tools like this one, a cost estimator tool that allows patients to calculate what they're actually going to have to spend out of pocket. Let me mention a system that is doing much of this all at once. Basically also innovating around some of the tools available in the Affordable Care Act to create accountable care organizations. North Shore Long Island Jewish on Long Island, creating a separate Care Connect subsidiary now, acquiring a state insurance license, and taking a system that was driven classically by volume and turning it into a system that is now going to be driven by value. The providers are the hospitals in the network and the physician practices already in the network. And now under CEO Mike Dowling, getting into, as he says, the health promotion business as well as the illness treatment business, moving away from fee-for-service. And as he says, learning from the people who are already doing it. He borrowed a leaf from Intermountain and Geisinger systems and having their own health plan so that they had a sweet spot where what they lost on the provision of care and the revenues from that, they picked up because on the insurance side, less cost is a good thing. They've offered a plan now on the New York Health Insurance Exchange. It's tiny right now. They're going to start small. It's a 10-year effort, Dowling says, and at the end of 10 years, they'll know if it will be successful. These are examples that are real, and again, as I say, I could talk about many, many, many more of them. But they're real, and they're all being driven by people like you who are gathering together in social networks like this one, learning about the innovations that others are undertaking, studying the patterns, making the calculations that you need to make to do this safely and responsibly in a financial and fiscal sense, but doing it. So let's close with some conclusions about health system transformation. I think Don Berwick was right when he said a couple of years ago that there has never been a better time to be an innovator in healthcare. It's obviously a scary time. It's a financially stressed time, but it's also a time where those who are innovating have the wind at their back. There is so much more of an appetite for system change around the country, even in the halls of CMS. Those of you who've had experience with that may find that hard to believe, but I can assure you it is the case. And for the skeptics out there, I would just commend you to the statement of the late, great James Baldwin, the famous novelist and playwright and essayist, who once said, "Those who say it can't be done are usually interrupted by others who are doing it." And I think I've just tried to show you a few examples of people who fall directly into that category. Bob Ross, who is the head of the California Endowment, said very pointedly recently that when it comes to addressing today's urgent social problems, and let's face it, health care is one of our urgent social problems, he says innovation's overrated. The greatest impediment is not thinking up new innovations, it's scaling up the solutions that we know work. And maybe that is the right example, because there's no shortage of innovations, as I've mentioned and as others of you are well aware. Maybe it is just seizing the ones we have and spreading them as quickly as possible to make them work. We know this is going to result in tremendous change, and Bill Gates has a wonderful observation that we as Americans in particular always overestimate the change that will occur in the next 2 years at the risk of underestimating the change that will occur in the next 10. And if we really do bring to bear all of the tools and change strategies that we now have in healthcare, we can imagine we will have a very, very different system 10 years from now, and it is hard to believe that it will be a system that doesn't produce better health care, and costs less. And of course, it has to happen. So I'll close with the observation of the late, great Jerry Garcia of the Grateful Dead, who once said, in a somewhat different context, somebody has to do something, and it's just incredibly pathetic that it has to be us. And I close there because it frankly puts the responsibility back where it lies, which is on all of us, on all of you. you who have already done so much to get us as far in U.S. healthcare as we have come, and have enormous opportunity to confront the challenges that are disguised as challenges, but really are the opportunities to produce better health, better healthcare, and have it all cost less. And I thank you so much for being able to talk with you this morning about it. Thank you.
Thank you, Susan. That was a great lecture, and of course, I'm so happy that you were able to recognize and acknowledge and showcase some of the great work that all of you are doing in the field today. Again, it's really important that we all work hard to make care better, safer, etc. So we're going to close the session, but before I do, I want to remind you there are 4,095 other individuals here at Congress. And I really want to encourage you to make the most of Congress during this week. You got great opportunity to build your network. You heard from a lot of our great leaders today, Chris and Charlie, and of course Chris Candio, that building your network is very important to your success. I certainly wouldn't be standing here today if it weren't for the great mentoring I got from Tom Dolan. So I really want to encourage you to get out there, meet some new folks, and enjoy your Congress experience.